Alrighty, now moving on to health history, we're going to be talking about interview and therapeutic communication. So as you guys know, the purpose of a health history is to really dig into the history of the client. We're simply collecting subjective data, really what the client says about themselves. Now this is very different from objective data. Objective data is what you observe with objective data. Now we're observing through measurement, inspection, palpation, percussion, auscultation, really anything that you observe. So the health history provides a complete picture of both past and present and even the future. Well, we're trying to dictate that future. So for a healthy person, we would assess multiple different things and we would assume a healthy lifestyle, right? So exercise, healthy diet, substance use is being avoided, reduction in risk-taking behaviors. But for ill people, we would assume the opposite, right? So the health history might include chronic issues and chronic health problems. So just remember, a health history is simply a screening tool for abnormal symptoms to address health problems and health concerns.
So what we're doing in this health history is we're really interviewing our patient. The goal of this is to get the patient to tell you the whole truth and nothing but the truth. So how do you get someone to do that when they just met you? Because you're going to be asking a lot of personal questions. You're going to be asking about sex, drugs, rock and roll. And how do you get them to spill their guts to you when you just met them? I can think of people that I've known for years that I don't trust enough to tell that stuff. And so a lot of that as the nurse comes down to building trust and rapport. But again, how do you do that in the short amount of time needed? It's all about therapeutic communication. How you speak to them, the words you used, your eye contact, your body language, how you convey empathy, making sure you use eye contact, not too much because that can creep your patient out, but not too little because that can seem disinterested. It's all very important. When we start with our health history, it begins with that client's chief complaint, which oftentimes we call the HPI, which stands for History of Present Illness. I like to think of it as the history of that illness they are presenting with. So basically said a different way. We like to document this using clients' direct quotes, and it leads us to why the client is seeking care. So that chief complaint is the reason for what they're seeking care about. Why are they here? Usually this is going to be a symptom, not a sign. So it's not a diagnostic statement. We wouldn't say something like, patient is here to rule out MI. Instead, it would be patient's here because of chest pain. So for example, if a patient comes in with shortness of breath, you might write emphysema. Even if it's known that the patient has emphysema from a previous visit, it's not the chronic emphysema that prompted this visit. What's prompting this visit right now is that increasing shortness of breath they've had for the last 4 hours. So some sample statements would be things like sore throat for the past 3 days and just getting worse, earache and fussy all night. Or sometimes the clients come in and it's not an illness. Maybe they need a physical exam for work. So we would put that down as their chief complaint or their reason for seeking care.
Nursing school is hard work. SimpleNursing.com makes it simple. We take your classroom lectures and notes to create a handcrafted study plan with specialized videos and visual study guides that highlight only the top-tested need-to-know key points, coupled with thousands of practice questions to test your knowledge, all neatly organized in our new app. Try it for free today. Visit SimpleNursing.com. Now, sometimes clients will come in and self-diagnose based on WebMD or similar signs and symptoms that they heard from their friends. And trust me, WebMD already says that I'm dead, so. Now, you'll see this a lot in the clinical setting, especially if you worked in the ER like I did. So we have to gather information from the client rather than just record that self-diagnosis and write out the symptoms. So remember, this is just what the patient says. It's their subjective data assessment here. So remember, symptoms is what you tell me. So look for that Y in symptoms is for the you. It's what the client is telling you. But a sign for signs and symptoms, think of the I in sign as what I am finding out about my client. So for example, if the client says, I have a fever. Well, that is a symptom because you are telling me here. Now, if we take the temperature and it's high, then that is a sign because I took the temperature here. So as you can see, a sign is an objective abnormality. So it's an objective assessment. It's what you observe. Or let's just say the leg is swollen and warm to touch. That would also be a sign because I am doing the assessing.
So if it is that they are presenting with an illness, we do that HPI that I mentioned before, which stands for History of Present Illness. So for that sick person, it's going to be a record of the reason they're coming in to seek care, from the time of the first that they experienced that symptom until now. So if the concern's been happening for a few months or a few years, we're going to see what occurred during that time and try to figure out why they're coming to us now about this. So your final summary should include the symptom and include these 8 characteristics. One would be location. You want them to point to where it is. For example, if they say headache, well, where that headache is can tell us a lot. If they say it's mask-like pressure, that could be a sinus headache. If they hit their head's going to hurt in a different place than that. So it tells us more information. We want that precise site so that we can get more diagnostic with it. We'd also want to know, is the pain localized? Is it radiating, superficial, deep? So we really get specific about that location. The next thing is we ask about quality or characteristics. So we want things in descriptive terms, like is it sharp, burning, dull, aching, throbbing, shooting? And we use similarities. We could say, does it look like this? Does it feel like this? For example, does blood in their vomit look like coffee grounds?
Right.
Because that could indicate that it's been digested in some way and it's a bigger concern. We can attempt to quantify it. If they have pain, oftentimes we'll ask them to rate it on a scale of 0 to 10. Or if they're coming in with complaints of profuse menstrual flow, then we might ask, how many pads have you been soaking and in what amount of time? We can even ask them, how is this affecting your daily activities? How bad is this pain or this issue? A patient might say something like, I was so sick I've been doubled over and couldn't move. So that also helps to tell us a little bit more about the severity and how bad it is. Then we look at timing. What's the onset? When did it start? And what's the frequency? Does it come and go? Is it constant? Is it intermittent? Does it seem to be surrounding any type of event? Do you only get a headache after you've been at school all day or working on a computer all day? And then any duration. So when did the symptom first occur? What's the specific date? And how long ago was that? And so we always ask things like, was it steady, constant? Does it come and go? Did it resolve at any point? And does anything make it better or worse?
Now the next one, number 5, is setting. So we simply ask, where was the person or what was the person doing when the symptom first started? Really, what brings it on? Was it that big, thick nursing textbook that was giving them a headache? Was it the big nursing exam that was giving them a lot of anxiety, right? So really just what brings it on, when did it start? Now number 6 is aggravating or relieving. So really what makes it better and what makes it worse? So is it aggravated by weather, like allergies commonly are? Or activity, does the pain get worse when you walk? Or after eating some type of food, like my dad, he gets epigastric pain or that heartburn after eating fatty foods. Or even medications, or some type of way that you're standing. Or does the client get fatigued at certain times of the day or certain seasons? And really just ask what relieves it. Does the pain go away when you have rest? Does the epigastric pain go away with Tums? Or really anything. And we're really just asking the client if they've tried anything or what seems to help with that pain or with the issue. Now, number 7 is associated factors. So this is the primary symptom associated with any other signs. For example, let's just say the client has a UTI, that urinary tract infection. So they complain of urinary frequency, but they might also have burning associated with that urine, as well as fever and chills. And lastly is number 8, the client's perception. So we want to find out the meaning of the symptoms by simply asking, how does it affect the daily activities? So we can just simply ask, how has this affected you? And is there anything you can't do now which you can do before? Now, many nursing schools, and even when I worked in the ambulance and the ER, we always use the acronym OPQRST and even the U for pain assessment. So as you guys know, O is for onset. So when did it first start, right? P is for provoke or provocation here. So what really makes it worse or what makes it better? The Q is for the quality of the pain. Is it sharp? Is it stabbing? Trust me, we always do this for chest pain. So we want to make sure that it's not a heart attack or some type of heartburn. But we usually have to do a diagnostic for that. Now, R is for radiating. So for the example of a heart attack, usually what happens is that chest pain radiates to the jaw or down the arm, right? And then S is for severity. So on a scale of 0 to 10, what is the level of pain? Or as we say in the ER, on the level of 0 to 10, 0 being no pain or 10 being stepping on a Lego, what is your pain level? And then T is for timing. So when did it first start and do they know a time? Now the U has just been added recently. This is simply the client's understanding. So what do they think is really going on? So we use it holistically to try to include the client in their plan of care here. Now, it is a new addition, so it may or may not be used in your clinical setting or even your school. Now for a few practice questions. So question number 1, a client has presented for care with complaints of persistent lower back pain. When assessing the client's pain, which statement made by the nurse would be most appropriate? Correct answer here, what makes your pain better or worse? And a second question here. A nurse is interviewing a client complaining of abdominal pain for the past 2 weeks. Why is a history of the present illness vital to treating this client? The correct answer is a complete description of the present illness is essential to an accurate diagnosis. Okay, now moving on to current medications. The key term to know is medication reconciliation. So this is a comparison of the list of current medications with a previous list from that client, which is done at every hospital and every clinic visit. Now the purpose here is to reduce errors and promote client safety. So for all currently prescribed meds, we have to note the name in generic or trade, but always know that generic is most tested on the NCLEX. We're not using trade names anymore. Now the client may not realize they are taking some of the meds from different providers, so we have to consolidate those. Now dosage is also noted as well as schedule, and we simply ask, how often do you take it each day? Or what is it taken for? Or really, how long have you been taking this medication? And another question is, do you see any side effects? Now, if the client's not taking it, then we simply ask, what is the reason you stopped taking the medication?
So some important things that we include with this that patients often forget to tell us about are their non-prescription and over-the-counter medications. So we want to ask about things like aspirin and other medications because many don't consider it a med, especially if they're not taking it every day, or they might be taking it more than they realize. So other medications to ask about, vitamins, birth control pills, sometimes they forget to include that, antacids, any cold remedies, acetaminophen, especially they might be taking Tylenol, and they could also be taking a cold medication that additionally has acetaminophen in it. And so that can cause liver damage if they're taking too much. We also want to ask about herbal medications. Many are safe, but some can interact with prescribed medications. And this is also a big question that gets asked a lot when you get into pharmacology.
Oh, yes.
Especially when it comes to interactions with some psych meds that are very important to note.
St. John's wort always is tested on for SSRIs or really anything. So watch out for St. John's wort. Now for a practice question. The nurse wants to ensure that a thorough medication history has been completed with an older adult client. Which checks need to be included? Select all that apply. Okay, let's look at our options. Medication name, yes. Medication dose, yes. Medication frequency, of course. We do the frequency, or we do all of these, in order to avoid adverse medication events that can lead to hospitalization, especially for our older adult clients. How about the next option? The client's understanding of the need for the medication. Yes, of course. Clients should always understand why they're taking the medication so they can keep on taking it and really have better outcomes. Now, the last one is a sleep log. Think about that. No, this one is incorrect. The client should be instructed to complete a sleep log if they have an identified problem here, but it's not really for medication reconciliation here.
Now moving on to a family history, which oftentimes can include a genogram. So the health status of the client's direct bloodline, as well as even their spouse, can highlight disease and conditions that the client might be at increased risk for. So especially if they're vulnerable for a certain thing, as far as they might inherit it, we may seek early screening and periodic surveillance because of that. So the purpose of a family history is to see the risk for certain disease states. A genogram is just a symbolic way or a graphic way to show that, and it can depict the gender, relationship, ages of immediate blood relatives, and we like to include at least 3 generations, their parents, grandparents, and any siblings if we do a genogram. Specifically, the things that we're going to ask about for a family history will be coronary heart disease, high blood pressure, stroke, diabetes, obesity, any blood disorders, cancers, especially breast, ovarian, colon cancer. We'll ask about sickle cell anemia, arthritis, allergies, any type of addictions or mental illness, suicide or seizure disorders, kidney disease, and TB. It's not that you would inherit it, but if they have any relatives that they are in close proximity to who have had TB, then they could be at risk for having TB.
Now for a practice question. During a health history, a client asks why family information is requested. Which response should the nurse make to the client? Correct answer, it can help identify any illnesses that you might be at risk for developing. Yes, this is the correct answer. The key terms there are any illnesses that the client might be at risk for developing. So don't get tricked on exams. The correct answer is not, it helps identify what health problems you are experiencing now. No, that is incorrect. And don't get tricked with another commonly missed option here. It helps to determine your longevity. No, that is incorrect. So always focus on the key words. It identifies any illnesses that the client might be at risk for developing.
So next in the health history, we're going to move on to the review of systems. This is basically a symptom assessment. So the purpose of this is to evaluate the past and present health status of each body system. You go body system by body system and double check any significant data that they may have forgotten about in their present illness section. And you want to evaluate any health promotion practices that might be applicable here as well. The order of this is roughly head to toe, but be careful. It's not the same thing as the head to toe physical exam. This is still subjective only. So don't be tricked. This is still subjective. No objective observations here. The big key point here, if they do have history of something, then you have to find out further information. So you have to do the OPQRST, and U if applicable, and that's a great way to find out more information. So for example, if they had a seizure as a child or as a baby, maybe because of a high fever, was there any medications given? Have they had any seizures since? Because that can be very different than someone who has a seizure disorder and who still consistently has seizures. So you'd want to find out more about what happened and where are they now.
Now moving on to functional assessment. This measures a person's self-care ability in the areas of general physical health or absence of illness. Now we've all heard ADLs, right? Activities of daily living. This includes bathing, dressing, toileting, eating, and walking. But there's also IADLs, which are kind of nice to haves but not need to haves in the regular ADLs. So these IADLs include housekeeping, shopping, cooking, laundry, using the telephone, texting your friends. That also sounds very need to have, but those are nice to haves, right? As well as balancing checkbooks, basically housekeeping work, right? Mm-hmm. Now, other components of the functional assessment could include nutritional assessment, social relationships, self-concept, and even coping, and even the home environment here. So we're always assessing relevant data related to lifestyle and type of living environment. Now, this may include sensitive topics related to lifestyle behaviors. For example, sex, drugs, rock and roll, right? We're getting very personal with our clients. Now, different screening tools may provide more objective validation of information with regard to substance or even alcohol abuse. Now for a practice question. The nurse is conducting a functional assessment of an older adult client. The nurse should focus questions on which area? So option 1, feelings about aging. No, this would not occur at this point in the assessment. How about quality of life? No, not in this case. What about recent personal losses? Well, the issues such as the client's feelings related to aging, quality of life, and recent personal losses may influence functional ability, but these are not the essentials of functional assessment. So the correct answer here is activities of daily living. Just let the name help you. Functional assessment, we're assessing the functionality of the client in their activities of daily living. So this would be correct.
Next up, we have the cultural and the spiritual assessment component of the health history. So this includes spiritual resources or maybe their religion, and as it especially applies to the care that might be provided in the hospital or what they will or won't want. So for example, if they're Jehovah's Witness, they may not want to be administered blood product. Or drawing large amounts of bloods from a Chinese patient might be prohibited as well. But we always want to ask, we never want to assume. We might want to ask any immunizations that they have been given if they are from a different country, especially if it's different from an immunization that we might be giving here. For example, there are some countries that give vaccines against TB. And so that might warrant further diagnostic procedures if we are trying to see if they have TB, because it might come up as positive on, say, the skin test, even if a chest x-ray wouldn't show that they're positive for TB. We also want to ask about any nutritional concerns related to their culture, their spirituality, or their beliefs. So are there any taboo foods or taboo food combinations?
Now for a few practice questions. Question number 1. In order to let an older adult client establish his or her cultural identity, which statement would be most appropriate for the nurse to make first? Correct answer is tell me your beliefs about the illness you are experiencing. Yes, this is correct. Experts always recommend letting the older adult client establish his or her own cultural identity by exploring cultural explanations of the illness. Now, question 2. The nurse tells a newly admitted client they're going to be doing a health assessment to help in planning care during the hospital stay. Before the physical assessment, what should the nurse do first? The correct answer is take a complete health history. Yes, we always want to start with that subjective data assessment.